Home is a very intimate place, filled with memories, things that we love, familiar routines, and time with friends and family that bring color to our lives. When you provide care in a home, you naturally learn a great deal about your client's life. Knowing details of clients' private lives may make the experience more personal, but it also brings a major responsibility. As a healthcare provider, you are responsible for protecting your client's privacy. Confidentiality or privacy is very important in healthcare. All healthcare providers, including doctors, nurses, home care providers, and companions, are required to keep client information private. To understand the importance of respecting your client's right to privacy, try putting yourself in your client's place. How would you feel if your care provider talked about you, your medical condition or habits, to neighbors, friends, or other clients? Each of us wants to be treated with consideration, and we all deserve the right to choose what information is shared and with whom it is shared. Protecting your client's right to privacy is respectful and professional. It is an essential part of your job as a care provider.
I think in our industry, the hardest concept to get across is that you're dealing with people's private health information in a home setting. And when I'm an employee and I work in a hospital or nursing home, you just get this aura about I'm in a medical facility and there's procedures and rules, and you're kind of guarded on what you talk about. But in a client's home, it's friendly and warm, and it's so easy just to share, and you can forget that that is private information. So just the natural home environment makes it even more difficult to remember you are a professional and you have private information, and it's your job to keep it private.
Privacy rights are legally enforced through HIPAA, a federal law passed by Congress in 1996. HIPAA stands for Health Insurance Portability and Accountability Act. The part of HIPAA that we are focusing on is the privacy rule, which define how healthcare providers must relate to protected health information, or PHI. Protected health information is any information that can be used to identify an individual in terms of physical or mental health, healthcare services provided, or billing and payment related to healthcare. There are 18 identifiers, and these are the most common. The patient's name. Any geographic subdivision smaller than a state, such as street address, city, county, and zip code. Dates such as birth date, admission date, discharge date, or death date. Telephone numbers and fax numbers. Email or website addresses. Social Security numbers. Medical record number, health plan numbers or account numbers. Certificate or license numbers. Vehicle ID numbers or license numbers. Finger or voice prints. Names of relatives. Patient information can be found in many places, including paper records, computers, printers, copiers, and fax machines.
One of the situations that presents itself very early on for us in a relationship with a client is when we go out for our first home assessment, they may tell us that they want the bill to be mailed to their post office box. And so they're giving us a directive already on how they want us to handle their protected health information. It may just be the name of our company and the service and the amount, but that's part of that whole health information directive that the client has the right to make, and we need to make sure we handle that seriously. Besides making them happy, it is their directive to us and we want to honor it, and it falls under HIPAA.
HIPAA requires that care providers use only the minimum amount of information needed to give care to their clients. Care providers are given basic information about their clients, such as name, address, phone number, and medical information necessary for them to do their job well. This is considered the minimum amount of information needed. For instance, if a client is diabetic, it would be important for the care provider to know so that he or she can prepare meals that are diabetic appropriate. Follow your agency's policy regarding minimum use of protected health information. Remember, reading client or patient medical records casually or to satisfy curiosity is a breach of HIPAA and can result in reprimand or job loss. Always ask yourself, what is the minimum amount of information I need to know in order to do my job? Minimum use also applies to providing information to someone authorized to receive it. Again, ask yourself, what is the minimum amount of information I need to provide to answer the request? HIPAA supports each person's right to place restrictions on how his or her private health information is used or shared. Before your first client visit, you should know who is authorized to receive private information regarding your client's condition or treatment. If you don't know, or if you are unsure, check with your agency before sharing private health information. Always check with your agency supervisor about sharing health information with any new visitor or family member. Don't assume that because it is a son or daughter that your client wants his or her health information shared. If your client wants information withheld from particular people, report the request to your agency's privacy officer, who will respond. Do not discuss your patients or clients with unauthorized people, such as friends, neighbors, family, or other clients. Never disclose your client's name, location, or lifestyle, or talk about things that occurred during your shift.
We have to spend quite a bit of time with our employees for them to understand this is not their role. They cannot give that information out. So going through these types of scenarios that they're going to deal with helps them understand, so we can kind of role play. When this happens, because we know the neighbor's going to come over and ask, she probably is watching for you to drive up to the driveway.
Hi, I'm Juanita's neighbor. How is she doing? What happened?
How do they redirect? How do you have an answer and not be rude?
You know what? I bet she would love to see you. Why don't you come over and visit?
Okay, I'm coming next Friday.
All right, well, I'll let her know that you came by.
Our employees being very social in nature, they like people, that's why they're drawn to this industry, can sometimes start chatting about the person they've seen before. Oh, I was at so-and-so's house. You might know, maybe they have the same last name. And so those are all parts of human nature that are very hard to break. And so again, it takes a lot of training, talking about all these situations, so to be like, oh my gosh, I would have done that. I would have never thought of that as being a HIPAA violation. One of the other situations that comes about is an employee may have been at a client's home that was just exhausting and frustrating. And now they go to the next client's home, and that client's real friendly and bubbly and likes to talk. And they say, gosh, it looks like you're really tired. And the next thing you know, you're saying, oh, I was at Susie's house this morning, and oh my gosh, she just had me running like crazy, and she can't hardly do anything for herself, and I had to take the cat litter out, and then on and on and on. And now here you just shared all this information about your first client with your second client, and that's a breach of HIPAA. but how easy it was to do because that client was so nice and just wanted to hear about your day. But you couldn't tell her all those details about your day because that was private. And now you've had a breach of HIPAA and you may have not even realized it. Another situation is you're at home and maybe you're doing some charting at home. You can't have that exposed to your spouse and children. That's someone's name. What if that is the name of your child's teacher? You know, now you have a whole new avenue of information that's exposed to a child. They don't even realize what they've seen. So home care presents a whole lot of unplanned, unexpected opportunities for health information to be breached. So the more things we can talk about and expose and think through, the better prepared we are.
Train yourself to keep patient information private.
How's your job going?
I love my job. It can be tough at times.
So are you working with any challenging patients these days?
Well, you know, I can't really talk about my clients. I have to keep client information private.
I understand that.
Yeah. So how are you doing though?
I'm doing good.
That's
I'm doing
good.
really good.
Doctors and clergy members must follow HIPAA guidelines too. For example, if a doctor visits as a friend rather than as your client's physician and asks about your client's health, remind him that you have the same responsibility to protect private health information as he has with his patients.
That's nice. What's his blood pressure like?
Because you are his friend and not his doctor, I have the same responsibility that you have.
When you talk about clients to others who are authorized to receive that information, try to prevent anyone else from overhearing the conversation. Whenever possible, hold conversations about clients in private areas.
Okay. Address? Okay.
Sometimes we call the employee and they might be at the grocery store. Because we're not in the building, we're out in the public. You have to be very conscious of, you can't just start answering the question. And the caller might not realize where you are. So it really makes you be much more conscious before you just start responding and answering questions as to where are you? Are you in a private area?
Never give your personal cell phone or home phone number to clients. Clients must communicate directly with the agency about their needs, rather than relying upon you as if you were a personal friend. You may feel very friendly toward your client, but you must remember your role as a professional care provider. You can share private health information about your client or patient when visiting the office of the client's doctor, at the pharmacy when picking up your client's prescriptions, with a supervisor or co-workers involved in that client's care, to 911 or the hospital, with a relative or friend who has authorization to receive private health information about your client. Your client has the right to view his or her own private health information and to copy it. Depending on your agency's policy, the patient or client may need to sign an authorization to release information form. If a client asks to view his or her medical record, contact your supervisor or designated privacy officer who will handle the request. When you're in the office, use good security practices to protect health information. Keep client records closed after use. Never leave any protected health information on desks, conference rooms, or open areas in the office. This includes notes, labels, or forms with patient names. If you see a record in public view where others can see it, take it to the appropriate person or your supervisor. Only people with a need to see information about clients should have access to records. When client records are not in use, they should be stored in locked cabinets or a locked room. For optimum security, double locking is recommended. Store keys in a secure place. Private health information, such as copies of medical records or billing records, must be shredded or incinerated if it is no longer in use or needs to be destroyed. Any paper with private health information on it, such as Post-it notes or scrap paper, should be shredded as well. Printers, copiers, and fax machines should be out of public view. If you are seeing several clients in one day, take only the care plan or assignment sheet of the client you are visiting into the home, and leave the other records locked in your car out of sight. During your home visit, be careful not to leave private health information out where family members or others may see it. Any medical record should be kept in your line of sight during the visit. That means close to you so that you can see it at all times. Documents such as weekly assignment sheets or care plans containing private health information should be returned to your agency promptly for the client's records. When you give protected health information to a caller authorized to receive it, document it in your notes, giving the name of the caller, the date of the call, and a brief description of the request and information shared. Do not leave messages regarding private health information on an answering machine unless you have been given permission by the client or patient. When you are at the office, make sure that your computer is turned away from public view or has a privacy filter to protect client information. Password protection is essential to computer security. Never share your computer password with others. Memorize your password. Never keep a paper record. If you suspect that your password has been used by someone, notify your supervisor immediately. Make sure that you log out of programs when you are not using them. Log off the computer or lock the computer when you are away from your workstation. Only 10% of computer security is technical. 90% depends upon the actions of the person using the computer. In other words, you are the most important part of keeping electronic information secure. When using a laptop computer, keep it within your line of sight at all times or locked safely in the car out of sight. Some agencies require the computer to be cable locked to the car, in the trunk, or under the seat. Do not leave your computer or PDA containing protected health information locked or unattended in your car overnight, even in your garage. Keep it in your home in a safe location out of sight. If you are running an errand between visits that takes you to a public place, lock your computer in the car out of sight before heading out from your client's home. By planning ahead, you avoid others observing you as you safely secure your computer. The small size of personal digital assistants, or PDAs, which some people use to record notes or other protected health information, makes them easy to misplace. PDAs are also a popular target for thieves. The best way to secure your PDA is to carry it on your body in a belly pack or other container. If you are not wearing your PDA on your body, it must still be in your line of sight at all times. When not in use, lock the PDA in your car out of sight just as you would lock any item carrying protected health information. Follow your agency's policies regarding security codes, login, and passwords. Memorize your password and never share it with anyone else. When faxing, send only the minimum protected health information needed, and avoid sending sensitive health information, such as information on HIV or sexually transmitted diseases. Always verify the fax number before sending it. Do not include any protected health information on the fax cover sheet. Always use a fax cover sheet that includes a confidentiality statement. Take reasonable precautions to ensure that the intended recipient is either available to receive the fax as it arrives or has exclusive access to the fax machine. Retrieve documents from the fax machine promptly. If you see a coworker breaking HIPAA rules, report it to your supervisor or privacy officer in your
Hi.
agency.
Yeah, do you remember our kindergarten teacher? Yeah, she's my patient now. She's so sick.
HIPAA violations can result in disciplinary action or termination from employment. In addition to employee penalties, you can be subject to civil or criminal charges by the government. Fines or prison sentences can result from the following: knowingly releasing patient or client information to someone who is not authorized to receive it, gaining access to health information under false pretenses, releasing patient or client information with harmful intent, selling patient or client information. If you receive a complaint from the patient or client who feels that his or her privacy rights have been violated, contact your supervisor or the privacy officer at your agency. He or she will follow up on the complaint. As a care provider, you have access to information about your client's personal life and health. It is your responsibility to safeguard that information, keeping it confidential. Following HIPAA guidelines will protect your client's right to privacy and will also safeguard you and your agency.
I guess I would say the one thing that I would really want all care providers to know is if you're in doubt, don't say it. Because if you're questioning yourself, you probably shouldn't be sharing it.
Developing a warm human interaction with your clients or patients is one of the many rewards of providing care to others. It is a valued quality of being a good care provider, but it can also blur the boundaries between personal and professional. Remember, maintaining good professional boundaries makes it much easier to act in accordance with HIPAA guidelines.
Infection control is the responsibility of every employee in the assisted living facility, from the caregiver to the cook to the driver to the administrator. Meeting the responsibility of successful infection control protects both the resident and the employee from potentially life-threatening infectious diseases. In this video, we will introduce basic infection control concepts, including transmission and prevention. Standard precautions to prevent spread of bloodborne diseases will also be discussed. For an infection to occur, a series of events, known as the chain of infection, must take place. The chain begins with the infectious organism and its transmission, and finishes at the susceptible host. Preventing the spread of infectious diseases focuses on breaking this chain.
When we talk about the chain of infection, we're referring to a series of events or steps that must take place in order for an infection to occur. The chain of infection begins with the infectious agent, or the microorganism, or put more simply, the germ that is causing the disease. However, in order for that germ to become strong enough and abundant enough to cause an illness, it must have a reservoir, or a place to grow. In the assisted living facility, a reservoir could be anything from a dirty towel hanging in a bathroom, a piece of soiled linens or laundry, contaminated food that was not stored properly, or of course the human body. The human body makes a terrific reservoir for germs to grow. The human body is warm, full of nutrients, full of moisture, and many parts of it are full of oxygen, all of those things that are needed for most germs to grow and survive. Once the germ becomes abundant enough in its reservoir, it then needs a portal of exit, a way to get out of that reservoir. The portal of exit could be through direct contact, or of course in the case of a human body, the portal of exit could be through the mouth, the nose, in feces, in urine, of course as we breathe, or even through our skin. Once it gets out of the reservoir, the germ must go through a mode of transmission, a way to get from the reservoir eventually to the host. And we'll talk more about those modes of transmission in just a little bit. The germ then also needs a portal of entry, a way to get in. And you can simply remember that anything that can function as a portal of exit on the human body can function as a portal of entry. So again, the mucous membranes of the mouth, inside the nose, or inside our eyelids, our urinary tract, our gastrointestinal tract, for example, if we eat something that has been contaminated. The skin also can act as a portal of entry if it's broken. When intact, your skin is actually a wonderful defense mechanism, but if it's broken through a cut or through a wound, then germs can very easily, of course, get into the body. The last step in the chain of infection is, of course, the susceptible host. In this case, this is the person that comes in contact with this infectious agent or this germ, and all of the conditions are right in order for that germ to get into their body, survive, multiply, and begin to cause disease. As an employee in the assisted living facility, our focus is to try and break this chain of infection. If we can stop just one step along that chain, we can prevent disease. An infectious agent is a microorganism or a germ that can cause disease. While there are many germs we constantly encounter in our environment, a relatively small number of them can actually cause disease in human beings. Those that are of particular concern would include bacteria, viruses, fungi, and parasites. Bacteria include things like Staphylococcus, Streptococcus, germs you've probably heard of before like E. coli that of course can cause very serious gastrointestinal illnesses. Bacteria are one of the most common germs in our environment, and they are very common causes of things like skin infections. Viruses would include the human immunodeficiency virus, or HIV, the cause of AIDS. It includes hepatitis viruses like hepatitis B and hepatitis C. Fungi would include things like the cause of ringworm, a fungal infection of the skin. Fungi thrive in warm and moist environments.
Microorganisms can be transmitted through a variety of routes. In the assisted living facility, precautions to prevent transmission through these routes must be implemented.
Once the germ multiplies and becomes strong enough in its reservoir, it then needs a mode of transmission to get from the reservoir to the next susceptible host. These modes of transmission can be put into 4 general categories: contact, airborne transmission, vehicle transmission, and vector transmission. Contact is one of the most common routes of transmission in the assisted living facility. It can occur through things like direct contact, one person touching another person. For example, if I had some bacteria on my skin and I touched someone's wound with my bare hands, it could cause an infection of that wound. Contact also can occur through indirect contact. In this case, transmission goes from the infected person to an inanimate object and then to the susceptible host. For example, if I clean my hands with a towel and then leave that hanging in the bathroom, another person comes in behind me and washes their face with that towel, they could acquire an infection from the bacteria I left on the towel. Indirect contact could also occur through things like needle stick injuries. If a syringe or a needle and syringe are not properly disposed of into a sharps container and someone was to stick themselves with that needle, they could come into contact with another person's blood through this indirect transmission. Probably one of the most notorious examples of airborne transmission would be tuberculosis. However, other very common illnesses like colds and flus can be spread through airborne transmission. Each time we breathe air out of our lungs, very small microscopic droplets of moisture come out of our lungs into the air around us. On those droplets of moisture can be these small microscopic germs or bacteria being carried out of our lungs. If another person then breathes in those germs in the air, they can become infected through airborne transmission. Vehicle transmission again refers to an inanimate object such as a towel or a countertop or a sink faucet carrying a germ. Again, it is closely involved in indirect transmission as we described a second ago. The last one, vector transmission, refers to germs being carried and spread to a person by a bug or an animal. Of course, we know that insects like ticks and mosquitoes can carry diseases like Lyme disease or malaria, respectively. Fortunately, many infectious diseases that we're aware of, such as HIV, cannot be carried by insects or animals to humans. The key to preventing the transmission of infectious diseases in the assisted living facility, again, goes back to breaking that chain of infection. And one of the first things we can do to break that chain is to minimize the agents in the environment and to minimize the buildup of reservoirs in the environment. We can do this primarily through simple cleaning and disinfection. It is such a basic, simple process we do every day in the facility, but if not followed carefully and consistently, it can again contribute to the spread of disease. Some things to remember about cleaning and disinfection. First of all, you must clean before you can disinfect. In other words, if there is some material, such as some blood on a countertop, before you can disinfect that countertop, you first must clean up all the visible blood. Secondly, whenever we are cleaning or disinfecting in the facility, we should be covering our hands with latex gloves. When you begin with cleaning, remember to first rinse the area or the object with cold water. If you rinse with hot water first, you actually can encourage that material to adhere to the surface. So remember, first rinse with cold water. Then, with your gloved hands, wash the area down with just simple soap and warm water and paper towels. Once you have removed all of the visible material, in this case, visible blood on the countertop, you then want to go back and give the area a final rinse with warm water. If necessary, you can use a stiff bristle brush to remove the material from any cracks or seams on the object or on the surface. Now that you've cleaned the area, you're ready to disinfect. It's important to remember to use an appropriate disinfectant. The CDC recommends a combination of bleach and water. A mixture of 1/4 cup bleach added to 1 gallon of water is a very effective disinfectant. Remember to make this each day, as over time it degrades and becomes less effective. After you've cleaned the area, spray it down with your disinfectant, your bleach and water, and allow it to sit for a little while. It needs time to work. Finally, with your gloved hands, wipe down the area with some new paper towels and discard them. After you're done, remove your gloves and wash your hands. final thing to remember about breaking the chain of infection is to help protect our residents and ourselves from becoming susceptible hosts. While it's true that there are some infectious diseases that, regardless of how healthy your body is, can cause illness, there are some things you can do to help minimize your risk and minimize the risk to your residents. First, simple regular bathing to help remove germs from the surface of the skin. Regular oral hygiene to protect the teeth, the gums, and the mouth. Adequate fluid intake. Make sure your residents drink enough water or fluids each day. Persons with respiratory conditions such as emphysema or COPD may need to implement daily deep breathing and coughing exercises to help keep the lower airways clear of mucus. Finally, things like a well-balanced diet, plenty of sleep, and measures to reduce stress also help to keep the body healthy and maintain the healing process. It's also important that under your facility policies and under appropriate physician orders, staff members and residents in the facility receive the appropriate vaccinations that are available. This would include things like the influenza or flu vaccine every year, and for some persons, the pneumococcal vaccine.
Initially developed in 1987 by the Centers for Disease Control, universal precautions were issued to prevent the transmission of bloodborne diseases such as AIDS and hepatitis B. In 1996, the CDC published new guidelines called Standard Precautions that summarize features of various precaution methods, including universal precautions. When properly followed, standard precautions can help to prevent the transmission of HIV, hepatitis, and other bloodborne pathogens.
The CDC developed standard precautions to reduce the risk of transmission of bloodborne diseases. This would include things like HIV, hepatitis B and hepatitis C, syphilis, and many other life-threatening bloodborne pathogens. The key components to standard precautions include the use of personal protective equipment, such as gloves, gowns, and masks as appropriate. Hand washing. Hand washing is the most important piece of standard precautions. The proper disposal and handling of sharps, such as needles and syringes or perhaps contaminated broken glass. And finally, environmental controls such as proper cleaning and disinfection to minimize the risk of transmission from the environment. The most important thing to remember about standard precautions is that they apply to everyone. Every resident and every employee in the facility should be handled using standard precautions. We never want to assume that a person is safe. In other words, put more simply, when following standard precautions, we actually assume that everyone may be carrying some sort of bloodborne disease. The single most important and effective thing you can do as an employee in the facility to prevent infections is to wash your hands. Washing your hands not only protects your resident, but it protects yourself from anything you may come in contact with in the environment. When washing your hands, some things to remember. First of all, you must wash long enough. The CDC generally recommends 10 to 15 seconds at least when washing your hands. Secondly, when washing hands, it's not just the soap and warm water, but it's the friction as you vigorously scrub your hands back and forth that kills and removes the germs that are on your skin. The first rule of thumb is, when in doubt, wash your hands. It's really difficult to say you could ever do it too often in the facility. However, some times when you want to be sure you've properly washed your hands include after caring for any resident that has an infection, after touching any organic material, before performing any invasive procedure if that's appropriate under your job description, before and after handling dressings or touching wounds, such as before and after first aid, after handling contaminated equipment, before coming in contact with clients who are susceptible to infection, such as persons with a compromised immune system, before preparing or eating food, after handling blood or body fluids, and after any personal contact that may contaminate your hands, such as after sneezing, blowing your nose, or using the restroom. Finally, and of utmost importance, you always wash your hands after removing gloves.
Follow these steps when washing your hands. Use an easy-to-reach sink with warm running water, soap, and paper towels. Push your wristwatch and long uniform sleeves above the wrists. Avoid wearing rings while at work. It is recommended to keep fingernails short and filed. Inspect surface of hands and fingers for breaks or cuts in skin and cuticles. Stand in front of sink, keeping hands and uniform away from sink surface. Turn on water by covering faucet with a paper towel. Be sure to use warm water. Wet hands and lower arms thoroughly under running water. Keep hands and forearms lower than elbows during washing. Apply soap from dispenser, lathering thoroughly. Wash hands using plenty of lather and friction for at least 10 to 15 seconds. Be sure to wash all surfaces. Clean under fingernails if soiled. Rinse hands and wrists thoroughly. Dry thoroughly starting at the fingers. Turn off faucet using another clean paper towel.
Probably the most important piece of protective equipment, and certainly the most frequently used piece of protective equipment in the facility, are gloves. Gloves are to be worn anytime you anticipate contact with blood or other body fluids. Gloves are to be removed after each task. They are not to be reused between residents or from one room to the next. Secondly, wash hands as soon as possible after removing gloves. Remember that gloves cannot be washed, decontaminated, or reused.
Remove the first glove by grasping cuff and pulling glove inside out over your hand. Discard glove. With ungloved hand, tuck finger inside cuff of remaining glove and pull it off, inside out. Discard second glove.
While these do not need to be used for routine tasks in the facility, they should be used anytime you anticipate splashing or splattering of blood or other body fluids. Additionally, masks are to be worn covering the nose and mouth during close contact with a symptomatic resident. For example, if you suspect that a resident has a severe respiratory infection and you are waiting for emergency medical services to arrive, it may be appropriate at that point to wear a mask. While it's never possible, of course, to create a sterile environment in the facility, there are some things we can do to help keep that environment as safe as possible. This would include proper cleansing and disinfecting of common areas, bathrooms, showers, toilets. This would also include proper cleansing and disinfecting of commonly used items in the facility, such as dishes and utensils. Environmental controls also include keeping linens and laundry properly cleaned. Some things to remember when handling soiled linen. First, be sure you wear gloves anytime you're handling linen that is soiled or could be soiled with blood or body fluids. Second, soiled linen should be placed in plastic laundry bags to avoid future contact with blood or body fluids on those soiled linens. Finally, when handling soiled linen, be sure to carry it away from your body. Handle things in small amounts and fully extend your arms to be sure that the soiled linen does not come in contact with your skin or your clothes. Handling and proper disposal of sharps in the facility is an important safety measure we take when following standard precautions. All sharps, including needles, syringes, or contaminated broken glass, should be properly disposed of in a sharps container. The disposal of the sharp is the responsibility of the user. So for example, if a resident gives themselves an insulin injection, it's the responsibility of the resident to dispose of that sharp into the container. It would not be disposed of by the caregiver. Infection control in the assisted living facility is one of the most important things that we do every day to help keep ourselves and our residents safe. While some of these practices may be time-consuming and sometimes you may feel that they're unnecessary, it can't be stressed enough how important they are to keep you healthy and to keep your residents safe. Remember that by following standard precautions and other components to infection control in the facility, you are doing your part as an employee to protect yourself and to protect your residents.
Home is a place where most of us feel completely safe and comfortable. For some elders, however, home is not a safe refuge. Behind closed doors, these older people are victims in the tragic drama of elder abuse. Elder abuse is the mistreatment of an older person by someone who has a relationship with the elder. It could be a spouse, adult child, friend, neighbor, or caregiver. According to the National Center on Elder Abuse, more than 2/3 of the abusers are family members. Elder abuse can happen to anyone, by anyone, regardless of his or her social class or ethnic background. The results of elder abuse can be seen in the unnecessary suffering, injury, and violation of human rights of the elderly. Hello, I'm Marian Karpinski, and I'll be your host during this program. Elder abuse can happen anywhere. It can happen in group homes, such as foster homes, nursing homes, or assisted living facilities. In this program, we will address elder abuse in the elder's family home. Elder abuse can be difficult to identify. Some diseases and chronic illnesses can mask or mimic the visible signs of abuse. For instance, some diseases may cause people to bruise more easily. Weight loss may be a symptom of a disease, a caregiver's failure to provide adequate meals, or an elder who refuses to eat nutritious meals. Elder abuse is very complex. Generally, a combination of factors contribute to elder mistreatment. Abuse is often inflicted in a subtle way, especially if it's premeditated and deliberate. Abuse can be the result of a history of family violence that continues into the person's later years, or violence that begins with a new relationship, such as marriage. Violence is a learned behavior that in some families is passed on from one generation to the next. In these families, abusive behavior is their normal response to life because they have not learned other more appropriate ways to respond.
Talking about the learned behavior and the learned violence, I think that it's very important to understand that we all grow up learning how to behave in a family from the family we grew up in. And if corporal punishment and if verbal abuse is part of a person's upbringing and they come up having that be the norm, I think it follows through and translates into older age that the child who was verbally abused is now going to use that same verbal abuse on the elderly mom or dad who is now bedridden or wheelchair ridden, and it think nothing of it because that's how it's done in this family. Unfortunately, I think that it then escalates because the response from the elder is usually nothing or very little because of their fear of making a bad situation worse. And so the frustration coupled with the learned behavior is a recipe for it getting worse. We know abuse gets worse. It does not get better.
Elder abuse may happen because the abuser suffers from mental illness or from problems such as alcoholism, drug addiction, and financial difficulty that makes him or her dependent on the elder for support.
If there's an abuser who tends to use drugs and alcohol, what we know is that that can give them, first of all, the permission to go through with the abuse, and secondly, it will accelerate it to possibly make it more dangerous and greater than it could have been.
Another contributing factor that results in elder abuse is caregiver stress. Not all stressed caregivers are abusers. For some people, the demands of caring for a frail older person, the absence of financial resources and support, and the lack of caregiving skills may lead to abuse or neglect. Without meaning to, a caregiver who lacks proper training can cause bruises, skin tears, and broken bones in the process of moving and positioning an elder.
One of the most common things that we see in elder abuse is sometimes what we misconstrue as caregiver stress, when truly what it is a continuation of family violence, domestic violence, that has probably happened in that relationship for a very long time. And now here we are as family members or healthcare providers, and we have a spouse who's coming to us and saying, you know, it's so frustrating to be the caregiver here because it's just so stressful, and I just am at my wit's end half of the time. And if we say to that person, well, I understand how it is, I really do, it's a very stressful situation, and we are somewhat giving permission for that to continue. We're justifying the abuse because of the caregiver stress.
Ageism is a form of prejudice against older people based upon negative images and stereotypes. Ageism increases the risk of elder abuse. The abuser uses these prejudiced attitudes to justify mistreatment of an elder. The definition of elder abuse varies from state to state, but it is generally agreed that the forms of elder abuse include physical abuse, sexual abuse, emotional or psychological abuse, financial exploitation, neglect, self-neglect, and abandonment. It is important to know what signs and symptoms to look for in identifying each form of abuse, because the abuse is often well hidden by the victim and the abuser. According to most state statistics, neglect is a leading form of elder abuse. Neglect typically means the refusal or failure to provide the necessary care to an elder by someone who has assumed that responsibility. It includes the refusal or failure to provide an elder with life necessities such as food, water, shelter, clothing, personal hygiene, medicine, and personal safety.
What caregivers need to remember is that if they are assuming the role of a caregiver, and this could be a paid position or an unpaid position, that they have a certain level, a certain duty to perform their activities with the older person, which in many instances is a family member. I would urge people to understand that the states are becoming more proactive now when they're dealing with neglect situations. And in some instances, a neglect situation of an elder person, failure to provide food, not turning the person in a bed, which could result in, say, bed sores or decubitus ulcers, could rise to a criminal level. And in many states, there are prosecutions taking place now on this specific form of elder abuse.
Some of the signs and symptoms of neglect include unsanitary living conditions, such as a dirty home, fleas, the smell of fecal and urine odors, soiled linens, or lice on the elder's body. Other signs include untreated bed sores, poor personal hygiene, dehydration, and malnourishment. Unsafe living conditions such as no running water or heat are signs of neglect. Neglect can also include the failure to pay for home care services by a person who has financial responsibilities to provide care for an elder.
Self-neglect is another form of neglect, and this is when an elder person who's taking care of themselves does so at a risk to their health and well-being. Now, for instance, an elder person may not be feeding themselves enough, may not be hydrating, taking enough medicine, or taking too much medicine. What about their general living conditions? They may be living in a very dirty environment. And this is another form of neglect that we need to be very cognizant about.
Unintentional neglect may occur when the person assuming responsibility for care is incapable of providing that care.
When I first came here, I realized that my stepfather had dementia and he was getting worse. And my mother has had a problem with her knee and her hip, which turned out to be her heart and her lungs. And my mother could no longer care for my stepfather. And my stepfather could not care for my mother. They both needed care. They both needed help. And we didn't know where to turn at that point.
Financial exploitation is a very serious issue as it relates to elder abuse because as people age, they need to keep their monies for taking care of themselves, providing food and shelter, and also medicine. And there are some people out there that are intentionally trying to rip off seniors, whether they're friends, caregivers, or even fraud scam artists. And some things to be mindful about when you're dealing with financial exploitations. Who's got the check writing authority? Is it the senior citizen, or is it perhaps a caregiver that has been able to get their name on the bank registry? What about other legal documents, power of attorney, the sale of property or deeds or trusts are issues to look at as well.
Look for sudden changes in bank accounts or unusual banking practices, such as a withdrawal of a large sum of money. You may want to check the elder's bank signature card. This will alert you to any additional names that may have been added. There may be an unexplained disappearance of jewelry or personal property. The elder may complain of missing articles or money. Caregivers or family members may gain unauthorized access to the elder's ATM card and withdraw money from the elder's account without his or her knowledge. The elder who is bed or wheelchair bound or who has dementia is more vulnerable to this type of financial exploitation.
And also seniors are vulnerable to the regular scam artist, the door-to-door salesperson, for instance, who wants to sell a new roof, or the telemarketing person that intentionally targets the senior citizen because of their trusting nature and perhaps the availability of funds which they may have.
Emotional and psychological abuse really is one and the same thing. It is when an elderly person is being spoken to in a derogatory manner, is being told that they are stupid, that they don't know what they're doing, that they are a bother, when the person who is giving care to them withholds things that they need like medication, clean clothing, clean bedding, affection, food, attention. When the elderly person is made to feel as though they don't count, that their needs are not important, and that they are in the way. We find that often emotional and psychological abuse, verbal abuse, can be more damaging over a longer period of time than physical abuse can be. And we have found that to be so. And it drives the person who is being abused inward, which is what keeps them isolated and keeps them from getting help and encourages the abuse to continue.
Physical abuse is defined as the use of physical force that may result in bodily injury, physical pain, or impairment. Hitting with the hand or an object is only one form of physical abuse. Pulling hair, pushing, shaking, kicking, pinching, and burning include other forms of physical abuse.
There was one time when I walked in the room and he had raised his hand, backhand, to my son. And my son is 4 years old. And my son was like this, with his hands up against his face in fear of what my stepdad was going to do to my son. And of course, I stepped in and stopped that. But what was so sad was the dementia had made him very unpredictable. And at one point, when he had had a stroke, the nurses had even told my mother to hide the knives. He had taken knives to some of the portraits that he had done of my mother.
Force feeding, inappropriate use of drugs, and physical restraints are other examples of physical abuse. The signs and symptoms of physical abuse may be bruising or finger mark bruising on the arms or legs. Black eyes, welts, and rope marks are other signs of physical abuse. Broken bones, sprains, dislocations, open wounds, cuts, or punctures may indicate physical violence against an elder. It is important to look for signs and symptoms of abuse in areas that are not as readily visible as the face and arm, such as the stomach and back. Some abusers deliberately choose those places to hide the abuse.
Sexual abuse is a kind of abuse that we overlook in elderly people often because it is particularly shameful to them, so they don't reveal it to us as often. But sex abuse in elderly can include things like unwanted sexual contact, sex without being able to give consent, as in the Alzheimer's patient or disabled person, forced intercourse, any kind of sexually degrading acts that are against the person's moral belief. We see these things more commonly than we want to believe.
Of all the abuse, the sexual abuse of elders is something that they are very reluctant to talk about. Oftentimes, elderly women do not think that when a male child or grandchild or caregiver says something inappropriate to them that is sexually inappropriate, that there's anything wrong with it, because they come from a time and a belief system where men were given the right to speak to women in certain ways, and they don't think there's anything off color or wrong about it. But often that leads to further abusive situations. I think that it's very difficult unless there are outward signs like the obvious vaginal infections or bruising in the area or what have you, that a person really can tell when there is sexual abuse, unless the person who is being abused begins to give you clues. Oh, well, they want to always be in the room when I'm changing my clothes, or he insists on coming in the bathroom and staying there, and I ask him to leave, but he stays, and those sorts of things. Little clues that we need to be so aware of and pick up on and begin to ask more about.
Other signs of sexual abuse may be a change in behavior. For example, an elder who becomes severely upset when being bathed, dressed, or undressed. Torn, stained, or bloody underclothing, or unexplained vaginal or anal bleeding may also be signs of sexual abuse.
Deserting an elder person by a person who's assumed a level of care or duty of responsibility is called abandonment, and that's another form of elder abuse. A famous case that took place several years ago was when a caregiver, a family member, took their father to a neighboring state. This individual had Alzheimer's and was confined to a wheelchair. The caregiver put this father at a racetrack and abandoned the person with no intention of ever coming back. We see abandonment cases with a little bit more frequency now. Oftentimes the person is abandoned at a hospital or senior center or abandoned at a shopping mall by a caregiver with no intention whatsoever of ever coming back to get this person.
There are some general signs that may indicate abuse is occurring. For instance, the elderly person may complain of being mistreated. Watch for any sudden change in the older person's behavior. For example, a once very talkative person may suddenly become withdrawn and depressed.
The person who is being abused often is very reluctant to talk, is very shy and withdrawn. Upon inquiring if everything is okay in the household, will always say quickly, everything's fine, everything's just fine. When you begin to suspect that something might be wrong and you begin to push a little further, you will often notice that the abuser is in the other room listening to what is being said by the abused person. And as a result, the next visit you make will often find a reason for you not to come into the home. The closer you get to an abusive situation, the more there is to protect on the part of the abuser, and the abused person is more fearful than ever, and you will notice more and more agitation on their part because of their fear.
Abusers come in all shapes and sizes. No single characteristic identifies an abuser. An abuser uses whatever means possible to deflect attention away from the abuse. An abuser may be
someone who was unwilling or would be finding excuses for the home health nurse, for instance, to come into the house, would be making excuses for why this person can't be there. They're asleep, or they're having a bath right now, or they're at the doctor, or they're at the dentist, or they don't want to see you today. You would find normally that this person is very short and doesn't want to engage in any kind of a lengthy conversation with you. Often will speak out the window or with the door just slightly ajar. They do not want to be confronted because they have something to protect.
Sometimes it's very hard to identify someone as an abuser. And the reason is because they're often very charming. People really like them. They have a good sense of humor. And they're often leaders in the community. Maybe he had a Boy Scout troop at one time, leader in his church. Very convincing. An abuser is someone whose life depends upon their good manipulation, their good charisma with other people. And of course, behind closed doors, we know that there is an entirely different story here. First of all, we all need to get better educated. We need to understand the dynamics. We need to understand the resources in our community. We need to know what to do and to know all the warning signs. So that would be the first thing, is to really raise our own personal awareness. I think then as healthcare providers, another very important thing for us to do is to do some very good screening. When we ask the question, we will get an answer. When we ask about past abuse and present abuse, we'll get some insight into what is going on with this person and how their health is affected. And to do proper screening, we have to be very careful about this, very sensitive to the situation. In other words, you must provide that patient a time alone. And this could be the policy of your home health care or your hospital or facility, that every patient has that private time with his or her healthcare provider. So you can ask those questions in a way that makes it safe for them to say, yes, I am being abused.
Listen and take seriously any complaints of mistreatment from an elder. Here are some things to keep in mind if an elder confides in you about an abusive situation. Do not bombard them with questions or interrupt with comments. This may be a very difficult subject for the person to express. Do not jump to conclusions or make accusations. Always respond openly, honestly, and with sensitivity to the elder. Any complaints of abuse from an elder should be reported to the proper authorities. One of the ways we can help prevent elder abuse is to provide family caregivers with education and training in proper caregiving procedures. Families also need support and respite services. We all have a responsibility to help prevent elder abuse, and one of the most important ways to do that is to report it. Most victims do not report abuse because of their shame, denial, fear, and isolation. They may be unable to report abuse because of physical disabilities or because of dementia, such as Alzheimer's. It is very important that we make the report of suspected abuse on their behalf. If the elder is in immediate danger, call 911 to make the report. Most states will take a complaint of suspected abuse anonymously. If danger is not immediate, you can report suspected abuse to your local county adult protective services, whose professional staff will make the investigation.
Adult Protective Services was there within an hour to counsel with us, to tell us what our options were. They heard that we wanted our stepfather to be cared for as well. And what was so great about it was it ended up where my stepfather got the help that he needed and deserved, and my mother is cared for and has dignity, and there's peace in our home.
If you have difficulty finding your local Adult Protective Services number, you can call the National Elder Care Locator number at 1-800-677-1116 and let them know you want to report suspected abuse. They will let you know the number to call in your area. Many states have mandatory reporting laws for professionals who work with the elderly. If you are a mandatory reporter, and most health professionals are, follow your state guidelines for the proper procedure when reporting suspected elder abuse. The drama of elder abuse need not end in tragedy. When you become an elder's advocate, you break the cycle of isolation and secrecy that is at the heart of elder abuse. You may be the one person who can make a difference. Your involvement may be the key to restoring peace and safety to an elder's life. Use the resources available in your community to report suspected elder abuse.